Morning to you, ladies and gentlemen. My name is O.P. Yadava. I'm the editor-in-chief of Indian Journal of Thoracic and Cardiovascular Surgery and CEO of the National Heart Institute in Delhi. And I have with me Filip Casselman from Aalst, Belgium. Filip, welcome to India.
Thank you.
You've been a leader in the field, and I want to discuss with you this new trend of minimally invasive cardiac surgery. Now, what really I'm interested in is that what is the failure rate of this minimally invasive cardiac surgery as to what percentage of patients actually you have to convert into a standard stenotomy?
Well, good morning, first of all.
Yeah.
It's my pleasure to be here. And actually, this particular question was also very much our interest. We started minimally invasive surgery way back in our center. Actually, Dr. Van Herman was the big stimulator of the minimally invasive surgery in Aalst. And the minimally invasive mitral program was started in '97. So we have 20 years of experience now with almost 4,000 patients. These are not the numbers of India I just heard this morning, but anyhow. And also in the aortic valve, we had quite a large experience. And obviously there is a learning curve. But we wanted to know what is the incidence of conversion once you are beyond the learning curve.
Okay.
And this is what we actually investigated.
And what would you call that learning curve?
Well, that is obviously different from person to person and with the frequency that you do it. But I say if you perform this on a regular basis, I would say that as soon as you have performed, if you are a senior surgeon, not in training anymore, once you've performed above 50 cases, you should be trained, we think, especially also if the staff around you is trained, and if different surgeons perform it, then also the staff, the nurses are quicker trained actually.
Sure.
So we looked, and you may have different variety of reasons, and we may come back to that, but it appears to be a relatively infrequent problem. Yeah? We have different, let's consider aortic, minimally invasive aortic valve replacement, minimally invasive mitral patients, and then the mid-cap population. And overall, for each target population, it's about 2.5 to 3% conversion rate, which is not negligible, but on the other way, not also hugely important, because we also do, as the experience grows, more difficult patients.
Sure.
And when you look at the reasons for conversion, so the percentages are similar for the three particular, there's small differences, but not overall. But there are differences in the reasons for conversion, obviously. And there you can distinguish the mitral and the midcap together, because there you go through the thorax, and there a major reason for early conversion, and you could say, okay, is this a conversion, or could you call this a strategy change, is because of unexpected lung adhesions.
Sure.
And it's not infrequent. I mean, from the whole percentage of about 3%, about half of it is early conversion because of lung adhesions. Actually, in the mitral population, it's even above 2%. In the aortic group, however, which we do through minimally invasive through J sternotomy, we don't or hardly ever use the right anterior thoracotomy. So as we go through minimally invasive J sternotomy, there the lung adhesions don't play a role. And there the reasons for early conversion are mostly related to cannulation issues. Because we cannulate the ascending aorta through the incision here, but we do percutaneous venous cannulation with double venous cannulation. And there may be some issues by placing the jugular cannula or the percutaneous venous cannula. So in aortic population, cannulation issues, mitral and midcap, mostly adhesions.
Well, I appreciate that, and it becomes all the more problem for people like us in India, where pulmonary tuberculosis is so rampant. So subclinical pulmonary tuberculosis, and even most of the pathologies that we have fair element of underlying inflammation, and so we find even a fair number of our coronaries would have flimsy adhesions. Doesn't take much, just swipe your hand around and the adhesions break. But nevertheless, probably for a minimally invasive, that would be a factor.
That's important. And I would also stress that if you do have pulmonary adhesions, unless it's one little one here or there, then it's okay. But if you have firm adhesions, stay away and convert, because we've had also issues where we wanted to keep going and really wanted to perform the procedure minimally invasively, but you have air leaks post-operative, and then you really go into trouble. So Our strategy now is if you have significant lung adhesions, then we convert. Yeah.
Now, the second question which really comes out as a corollary is this conversion absolutely safe, a benign event, or is that a very serious?
Well, there you have to make the difference between the early conversions, which we just discussed, and the late conversions, which we have not discussed yet. The late conversions obviously are the remainder of the cases. Yeah? And there, in valvular surgery, both aortic and mitral, the late conversions are mostly due to bleeding. Or uncontrollable bleeding by minimally invasive means. Yeah? In mid-cap, it's a different story there. The late conversions are mostly due to ITA dysfunction, IMA dysfunction. If you look at the converted patients, at the late converted patients, because of medical issues, I would call it, yeah, because the early conversions are mostly technical issues, yeah, then the morbidity and mortality related to the conversion is quite substantial, and the mortality associated with the procedure is ×3 to ×5. Now, I have to comment a little bit on that, because the question, of course, is the mortality related to the conversion as such, or because of the reason for the conversion? Yeah. Because in mitral issues, for example, yeah, some of the patients that have been converted because of AV rupture, yeah, which we could not handle minimally invasively, so we converted to sternotomy. But intuitively, these patients don't die because of the conversion, they die because of the reason for the conversion. If it's the bleeding issue, if that's due in mitral issues due to AV rupture, then it's a different story, as it is a small bleeding from another point, let's say, for example, from the pacemaker insertion place. There, obviously, the morbidity or mortality is not increased. Yeah. Yeah. But overall, if we look at the late conversion rate, morbidity, mortality is substantially increased, so it's not a benign situation.
Now, to reduce, is there any element of a delayed decision-making also? Suppose the patient has been kind of, not behaving well, and you have delayed your conversion, could that be a factor?
Yeah, but the late conversion, which I'm talking about, is still intraoperatively. Yeah,
yeah, but so even in intraoperative, your decision-making, does it affect the...
Yeah. Well, it will depend especially on the reason of if you are confronted with the bleeding problem, the point is to determine what the bleeding, what is the cause of the bleeding. And if you can, with your swab, you can see, and if it's a bleeding on the pacemaker insertion place, either you can try to fix it minimally invasively, or you convert, and then if you also have to take all the factors into account. Also, echocardiographically, especially if you're doing mitral valve surgery, as soon as there is an assumption of an AV rupture, for example, then I would plead to go ahead and convert, because that's going to be difficult to handle.
So how do you avoid these conversions? Are there any practical tips in terms of selection of patient or any other?
Yeah, absolutely. I would argue that it is extremely important, especially for people that start minimally invasive surgery, and even people in their beyond initial experience, but still in a somewhat acquiring vast experience, to look for the right patients. And it's like in global cardiac surgery, try to avoid really obese people. Yeah? Try to have straightforward, no angulated iliac vessels, for example, in mitral valve surgery. We always do an MRI of the iliac vessels to be sure that there are no subtotal stenosis, atheromas, and especially if you go for redo cases, for example, redo after CABG, then atheromatous disease of the iliac vessels may play a role. So it's quite important to, because, for example, in the complications that we had in the mitral population initially in our experience were, for example, type A dissections. Well, because we didn't screen good enough the iliac arteries, and now we do that routinely, and as soon as there is a problem, then take it and jump on the problem and make sure you fix it. Don't wait at that point in time, and recognize the major complications.
So, ladies and gentlemen, in this era of minimally invasive cardiac surgery, there is still, despite some of us having got over the learning curve, a 2 to 3% chance that the minimally invasive will be converted into a sternotomy option. And it's not just the conversion, but also the reason why this conversion has taken place, which finally dictates what the end result is going to be. Certainly, conversion makes the patient a high-risk proposition. A good meticulous planning, taking care of the body habitus, looking at comorbidities is very important in avoiding these conversions. Well, thanks, Filip, for being with us.
It was a pleasure. Thank you very much.
Bye-bye.
Bye.
Thank you.